8:12 in the morning, it's the voice of Indiana County, WCCS, AM 1160, 101.1 FM. And Dr. Dan Clark is with us in our studio once more. We have been focusing all this month on breast cancer. It's Breast Cancer Awareness Month. We started the month with you. We're going to finish the month with you. Good morning.
Good morning. Good to be back.
It's good to have you back here today. And I love the topic because we talk about breast cancer, its prevalence, the diagnosis of it, the treatment of it, all of that. And we never get into this topic as well as we should, but I'm glad we have the chance to. Genetics and the connection to breast cancer.
Right.
Let's get into that a little bit.
Well, most people don't realize there's a lot of word out there about genetics nowadays, but actually still the vast majority of breast cancer has no genetic relation.
Mm-hmm.
You know, it's only about 20% of breast cancers that we see actually will end up having a genetic connection. However, we're finding we're at the tip of the iceberg with genetics. And as we've been expanding the role of genetics, we're finding more and more people who are susceptible to not only breast cancer, but other cancers as well. Mm-hmm. You know, so the BRCA gene is what we're talking about. It's BRCA1 and BRCA2, so we call it the BRCA genes. And it was so named for breast cancer, BR and CA. Mm-hmm. What we now know that it's related to a lot more cancers than just breast cancer.
Yeah. You introduced me to that term last year, and that was a fascinating term. And there are some real, well, I guess, indicators that you can follow, and I don't know if predict is the word for it, but they can help you to track people who are more susceptible to it.
Right, risk estimators is what we call them,
Okay.
and there's different calculations we've used to come up with your risk of breast cancer. You know, the Gale risk model. Now it's called the Tyrer-Cuzick breast cancer risk model, but they don't really take genetics into consideration. That's your overall risk based on your personal history, your family history, and such like that. I actually have a little sheet here that we use to screen people for breast cancer
Josh
risk.
is going to focus in on it on Facebook for us.
And it's a lot more expansive than just does your family have a history of breast cancer.
Okay.
You know, any woman under the age of 48 would qualify for breast cancer or genetic screening if they have breast cancer themselves, even if they don't have a family history of breast cancer. Mm-hmm. That's actually how I got involved in the genetic screening. My wife was 48 when she was diagnosed with breast cancer. Uh-huh. And there was nobody in my former group or area that was doing genetic testing. You know, we had to go into Pittsburgh for it. Mm-hmm. And I went and I sat with the genetic counselors with my wife and listened to that and realized that, you know, this was a need that needed to be addressed where we were. So I went out and got educated on it, and I've read intensely about it, and I keep what we call CMEs. We're required to maintain a certain number of readings and keep our education up in the area to stay certified as a genetic tester, you know, essentially. So as you know, we're applying for the National Accreditation for Breast Programs, and one of the requirements is to have a genetics counseling session with people or have that available, and I'm certified to do that, and so I brought that to Indiana County as well.
So Indiana Regional Medical Center is a place folks can go and undergo genetic screening for breast cancer.
Right. We have it right in our office. We have it set up every Friday right now. We have a screening. This form here talks about, you know, it's not only with breast cancer, but ovarian cancer is a big link to the breast cancer gene as well. So if there's any family members with ovarian cancer. The other things are pancreatic cancer. If family history of pancreatic cancer is linked to the breast cancer gene. Malignant melanoma, the skin cancer, we now know that carries a genetic link in some cases to the breast cancer gene. Wow. Young men with prostate cancer are linked on the same gene, you know, and any male in your family who's ever had breast cancer, that links, it puts you at risk for carrying the breast cancer gene. If you're of Ashkenazi Jewish heritage, puts you at increased risk for carrying a breast cancer gene. Wow. So it's very broad, and I explain to patients that, you know, it's called the breast cancer gene because that's the first cancer that we associated with this gene. But we now know it's associated with far more than just breast cancer. So all these are we have a simple screening form. We're going to get these out to more offices throughout IRMC as well, hopefully rolling it out with the OBGYN offices in the near future. And I've spoken with the UPMC, our Hillman connection of the IRMC Cancer Center. You had Dr. Ramanini on here earlier, and we're going to roll these questionnaires out there as well to try to broaden the screening for breast cancer.
Yeah.
And
Yeah. So at your office where you do it on Fridays, people need an appointment, and we're not just talking about women and breast cancer now. We're talking about general.
Right. We're focusing mostly on breast cancer, but if you have any of those other cancers in your family, you fit in that role for genetic screening. But this is also colorectal. I do a lot of colon cancer as well, and so we do the genetics for colorectal as well. There's a syndrome called the Lynch syndrome that is a genetically linked colorectal, one of the genetically linked colorectal disorders. And the nice thing is that we use this MyRisk program by Myriad. Myriad is the company that developed the BRCA gene.
Okay.
And so they have the largest repertoire or database of the cancers. And so with the MyRisk, you don't just get the BRCA gene, but it's a 23 gene sequencing that they look at. And it grows. It may even be more than that now, but it looks at colorectal, it looks at other pancreatic, it looks at a lot of different genes in your genetic risk. So if a patient comes in and has an appointment to see me for genetic counseling for this, they get more than just me.
Yeah.
What we end up doing is they come in, they watch a short video on genetic testing, and it explains the testing to the patient. Then we have a telecommunication link or telemedicine link with certified genetic counselors. So after they watch the video and decide they want to proceed on, pick up the phone, they talk with the genetic counselor, and they go over their family history. And then they determine whether or not they are candidates to have the testing. So we have certified genetic counselors on the phone who go through this and certify with them.
Yeah.
And then what's really nice about that is that there are guidelines out there. The National Cancer Clinical Network, the NCCN we call it, the American Society of Breast Surgeons, and the U.S. Preventative Task Force all have guidelines that whether or not patients will fit the criteria. So patients worry about their insurance. If you fit that criteria, your insurance will pay for it.
Okay.
So that's the screening. Before I even get in the room with a patient, that all happens, and it's determined whether or not their insurance will actually qualify for them for genetic testing.
And what's the procedure then? How is the test conducted?
Well, it used to be a blood draw. Now it's actually very simple. It's a gargle and a spit, actually.
Oh, yeah?
And we can get it from the cells lining your mouth. It's kind of scary how easy you can obtain genetic material.
Yeah.
But after they have that counseling, I sit down with them and go over the ramifications of the test, because it's not just a simple, blood test. You get a yes/no answer, and there's a lot more to that. So I explain to the patients that, there are ramifications, that we will change the screening patterns possibly. You may need additional tests, may even need additional interventions if this comes back positive. So I then explain the ramifications to them. And then they gargle and spit in a tube, and we can send it off to the company, and we get it back usually within 2 to 4 weeks.
Yeah.
We can get the results back.
Yeah. And of course, that doesn't necessarily, you have the gene doesn't mean that you have the cancer.
Correct.
Yeah.
The gene just puts you at risk. And if it's BRCA1 versus BRCA2, they have different risk patterns. But if you are positive for one of those genes, it's a 50 to 70 some % chance of developing breast cancer in your lifetime. Wow. So it's a significant. And I think you've heard me say before that when we look at breast cancer, lumpectomy and mastectomy have the same survival at 25, 30 years. The exception to that is if you carry the breast cancer gene.
Okay.
If you have a breast cancer gene and you have breast cancer, mastectomies definitely improve your survival.
Okay.
And so that's the big difference with somebody who is in that 20% of the population of breast cancer patients.
So the formula is BRCA equals evil.
And it equals information. It's preventative, too. This is not just for people who have breast cancer, but it's for people who have a family history of cancer. That we can now do preventative strategies. We can put patients in a high-risk screening protocol there we do mammograms alternating with breast MRIs every 6 months for early detection. So that's the high-risk screening protocol. We can test family members, so sons and daughters, because it's not just daughters, but it's also sons that are at risk. And that's a misconception that, it's only the daughters. But it's actually an autosomal dominant inheritance pattern, so you get it from either parent. So we used to just focus on the mom's side, the maternal side. We know that that's not correct now, and that you can get this gene from either side. So, if your father's mother had breast cancer and his sister had breast cancer, and maybe he had prostate cancer, or somebody else in the family had ovarian or pancreatic cancer, those are the things that should have the light bulb go off that maybe we're at risk for this.
You have to do some real detective work. I get the idea that this is really pretty exciting for you. This whole field of genetic research and genetic counseling and what it can uncover for a person in terms of their long-term health.
Yeah, it's exciting because we can prevent cancer. If you have this knowledge, there are things we can do to stop you from getting cancer. And that's what's exciting about it.
Yeah.
And we have to do it within certain time frames. Say you're unfortunate enough that your daughter ends up with having the BRCA gene. Well, I can sit down and counsel that, this is a lifetime risk. This is not a risk that's going to happen tomorrow. This is what we can do to allay the fears. And these are the things we can do so that we can get you in a screening program early. And we can either detect early or even completely present breast cancer, ovarian cancer, melanoma, because we get you in to see a dermatologist. So it's far beyond even just breast cancer.
Yeah.
So
Dr. Dan Clark is with us here this morning. So last year to this year, I'm sure that there have been advances that have been very exciting for you. Different ways you do things, different technologies that come forward. Predict for me what the next year is going to do. When we're back here next year talking about this same topic, what are we going to be talking about?
Well, it's hard to predict with the genetics because it's exploding. There are some of these reports, the most difficult ones I get back are what we call variants of uncertain significance. In other words, they found a mutation in the gene, but at this point, we don't know what it means. And as we go forward, most of them come out that we find that they don't have any significance because there are normal variations in genes. But I think as we go forward, some of these variants are going to find out that they now have associations. And we have some other minor genes that are going to increase that 20% of genetically related to a higher percentage that are genetically related, and then we can start testing for those and intervene earlier as well.
If you were not so involved in all this doctoring stuff, we could have you in here every week and we could get into these conversations. It'd be so much fun. It'd be so much fun and so informative. This is Wednesday. That means Walk-In Wednesday at the IRMC at Chestnut Ridge for breast cancer mammograms.
Right.
And of course, Mondays at IRMC main campus. That continues past October, right?
Absolutely. That's year-round.
Yeah.
You don't need a prescription. You don't need a referral from a physician. You can show up at IRMC on Monday and walk in and get your mammogram. And then in Blairsville, at Chestnut Ridge, we do it on Wednesdays. So that's year-round. You can just, if you don't have time and can't get to the doctor and you need your mammogram, just stop in one of those days and you can get your mammogram.
It's a beautiful thing. Thank you, and thanks to all of the others who have been able to come in and spend some time with us on these Wednesdays in the month of October.
And it really is a team that we have. We have my whole goal to get here, and you've heard me say this before, is that it needs to be a comprehensive breast center. And I've been here for a year and 4 months, and we truly are now a full comprehensive breast center.
That's exciting news. Yeah. Wow. Indiana Regional Medical Center. Dr. Dan Clark, thank you.
Well, thank you.
Have a great day.
Okay, you too.